Hello, I'm Janice Karin, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if you'll go to the first update, excuse me, folks. Chia has recently put out its first healthcare workforce survey results. This was conducted between May 2023 and January of 2024. There's an interactive report that lets you slice this in different ways. This is all from kind of the overall results slice. And they looked at a bunch of different areas, and they looked a lot at retention and diversity and stuff like that. So it's kind of like a report on the state of the workforce. And so the turnover rate among all of the different types of healthcare workers in the state were highest among direct care workers and full-time social workers, which is probably not surprising to anyone. Because the direct care workers category encompasses anyone who actually deals directly with patients. So that's a broad category of workers that also gets sliced further. They slice things both by type of position, which can be in different types of and type of work, and you can be like, so there'll be nurses who are also direct care workers and nurses who aren't, that type of thing, just as an FYI. So home health care had the highest turnover rate. So specifically for nurses, home health care had the highest turnover rate, almost 50%. And nursing, I'm sorry, my aside got me a little bit messed up. So still on the turnover rates, when we're talking just about nurses, home health care had the highest percentage at almost 20%. And then looking at vacancies specifically for nurses, because that's what they called out, because I think that's where a lot of the concern is. Home health care had the highest rate of vacancies at 20%, and nursing homes were right behind at 19%. And then they spent a bunch of time talking about diversity. And one of the things they pointed out was that at the leadership level, about 65% of the leadership positions are filled by white non-Hispanics. And for EMS services, that's 93%. And community health centers, it's only 37%, but it's still 37% in a area which is probably has the most diversity in population in general. And then across everything, the direct care workers were the most racially and ethnically diverse. But when you, again, don't look at the type of care, but just the category of care, home health workers were the most diverse at 81%, and nursing home workers the least. And so I'm not sure exactly how they calculated that number, because I don't know if that's supposed to be the number of minorities, because the percentage of diversity is kind of a weird phrase. But you can find the report at the link, and that again is interactive. You can click on different things and get different types of information, place things in different ways. Excuse me. So any questions about that? All right, let's keep going. ONC has put out a new request for comment on USCDI Plus for maternal health. So this will be the third USCDI Plus set that has been put out. The other two that we would probably possibly take a look at. The comments for this are due on July 31st. They have asked, obviously they're open to any feedback, as they always are when these comments are available, but they've asked some specific questions in the categories that are listed on the slide. And you can find more information as well as um, a way into starting to look at the data site if you're interested at the link below. You do need that full link. Those are not extraneous like add or how we got there elements. So just be aware that if you would like to take a look, that will go directly to the announcement of the comment. And then you can go to the general site if you want just to look at the data set. Any questions or comments there? All right, let's go to the next.
Janice, it's
Go ahead.
Denny. I just had a question about this. We talked about this earlier in an internal meeting, but I could see in the near term the advantage of having USCDI Plus because you want to start highlighting particular sets. You want to develop them in parallel to the full USCDI. But is there some expectation that at some point in time, these data elements that are being added to USCDI Plus will become part of USCDI, or are they always going to be sort of appended or categorized differently going forward?
Yeah, so that's a good question. This has not been confirmed. I have, and so far this has not been how things have gone so far. But the original expectation I had when USCDI Plus was announced, and the way it was somewhat positioned to give me this impression, was that USCDI is a set of data that every practitioner, everyone involved in healthcare will need. So it's meant to be like this is what is needed to practice the minimum amount of data needed to reasonably practice healthcare. And this is what we all need to have in a standardized way and what we should all be exchanging. But then to do specific types of healthcare, there might be data that's only pertinent to that type of healthcare. And so these USCDI plus sets were supposed to be identifying additional things that people working in those areas felt were 100% necessary, part of their minimum floor of data, but that were not necessarily things that people working in other areas of healthcare needed or felt was important to have for every single patient all the time. And so and it was positioned so that these are all developed in conjunction with another agency within HHS. And the general expectation that was put out was that those agencies would then use these data sets in their regulations and their rulemaking to make them part of the standard operating mechanisms for data exchange within those areas. Now, that has not happened yet, nor has the other thing that hasn't happened, which is something I've asked ONC about, and they've not made any type of comment about it, is none of these data sets are certified against. Now, none of them are necessarily finalized, so that may be part of it. Like, it's not clear that they all live on this USCDI Plus website now, and they're not clearly versioned, they're not clearly updated on any cycle yet. And so part of the process as well, one of the things that they asked about in the original USCDI Plus for Quality request for comment, which predates this website, was what type of update cadence would be reasonable and how should that process work? And so I think they are still trying to sort out some of this, but they haven't committed to any kind of certification, any kind of regular update cycle, or any kind of specific, and none of the other agencies have committed to any specific requirements for use in any of their programs. So right now, what we're doing, and I think part of why I'm pushing to comment on some of these when these opportunities come up, is we're trying to kind of set the baseline for how they should be used and what should happen with them. Now, the other piece, and I apologize for going on and on to answer a simple question, the other thing that's a little bit confusing is that, especially in the behavioral health one, which is the last one we looked at in detail, there were large swaths of the data set that were part of USCDI. And that was also true for the quality. So I think that that there's also some potential for confusion and room for there to be better guidance on how they fit together and what the intent is there. The other piece of the puzzle, or the other thing that's missing, is that the data sets are put up there as data sets without a lot of explanation for intent of use, which is kind of tied to what we've been talking about. But for instance, when we looked at the behavior USCDI plus for behavioral health, some of the feedback and questions that we had were we don't understand the intent of this, and without some specific intent that might make it understandable, this collecting stuff this way or putting this here doesn't make sense to us. And some of that was the overlap with USCDI plus. I'm sorry, with USCDI period from the USCDI plus. So there's basically a lot of open questions. This is still I would consider this like a nascent period where the bad side is we don't have answers to a lot of questions, and the good side is that maybe we can actually have more sway in how the answers turn out than we would in something that's much more fully baked at this point. Does that make sense?
Yes, thank you.
All right. Anyone else have any thoughts or questions here? All right, let's go ahead and go on to the next slide. So ONC has put out another data brief, this one on 2023 interoperable exchange of patient data in hospitals. And it looks specifically at what was going on in 2023. This is more, the last brief that we looked at didn't have a lot of graphics and a lot of, it was not quite up to the standards that ONC usually sets. This one is back to their normal standards. There's a lot of interesting data. There's graphics if you follow the link, if you're more of a graphical person. And there was some encouraging data here and also some concerning data. So one thing that I thought was encouraging was that 70% of the non-federal acute care hospitals said they engaged in what's called all domains of exchange, which includes sending, finding, receiving, and integrating. Because that's sort of been the missing piece to some extent, is the fact that people are not always integrating the data that they get into the system so they're available. And we'll come back to that because that's also one of the concerning points. And there was a definite increase in routine engagement in all of those categories from 2018 to 2023. But now here's kind of the downside of this integrate. So 71% of hospitals said they had routine access to necessary clinical information from outside providers. So that's a slightly different, more refined category than that 70%. That's why the numbers are different. And of the folks that said they were routinely interoperable, 92% of them said they had this level of, they had this particular data available. And 80% of those that said they're sometimes interoperable, so they had it. But of all of those hospitals that say they have routine access to clinical information from outside providers, only 42% of them say that it's routinely used while treating patients. And what's not clear is where that disconnect is. Is it that it's not integrated? I mean, my guess would have been that it's not integrated. And that's probably still at least somewhat true. But they were actually classifying integration as one of the categories that was part of being engaged in exchange. So it's not clear if it's, I still think that's probably at least a root issue, if not the root issue, but it's not clear if there were other issues such as too much information and therefore it was disregarded, or it's so digging deeper into that I think would be an interesting and key thing to do. But that was something that really stood out to me in the data that they had available. And the other thing that they pointed out was that as far as who's exchanging data how the data is getting exchanged. The hospitals say they most frequently exchange with other hospitals, followed by ambulatory care providers, then post-acute care, and the least likely type of provider the provider type they're least likely to exchange with. Sorry about that. Is behavioral health provider, which is probably at least somewhat because behavioral health providers are less connected and less likely to be using certified health IT and less likely to be using sometimes electronic systems at all. So that's not at all surprising, but they did point that out. So you can take a look at the full report again, see the spiffy graphics, etc. Slice some of this by type, hospital type a little bit more, stuff like that at the report itself. But anyone have any questions or thoughts in the meantime? Anyone want to pose another possible reason why that data is not getting used?
Do you mean by behavioral health providers, or
No,
do you mean
I'm
in
sorry.
general?
The hospitals that have access to clinical information from outside providers, but the clinicians aren't using it. Sorry about that. That
No,
third
no.
bullet.
Yeah, I would posit, Janice, that it's often embedded somewhere that they don't routinely review just because of workflow and access and integration challenges. Even though the data is shared, I'm guessing most of that is via like, Care Anywhere or Care Quality type of exchanges because of the, not quite ready for prime time TEFCA QHIN model. But
Yeah.
some of this would beg the question of if there's only a 42% usage of this shared data, then is that going to improve with other models, like the TEFCA model, for example?
Yeah. Or
And don't know.
APIs.
Yeah, I mean,
Yeah.
92% of routinely interoperable hospitals is a pretty high number.
Yeah. I mean, that's the thing, right? Because part of what they say, if you look at, you know, there's a much higher number than I expected of hospitals that say they are integrating the data into their systems. Now that could also have different meanings for different hospitals. But because that obviously was my first thought as well. But I don't know, it's something we'll see if there's more forthcoming on that. But that was certainly the
Yeah, I
big
mean,
thing
we
that stuck out to me.
just as a quick example, I mean, we implemented the shared community record here in the Northern Berkshire community, which was essentially a click through to a combined CDA document that was, sort of merged together from all the participating providers within the community. The ED doctors often would just say, "Well, I just didn't have time to click through it and look at it." That's the kind of thing, the kind of response you get when you ask the provider.
Right. Right. But I would say that's not integrated into the system. But maybe I'm combining
Oh no, it's a click right in when they're EHR. They literally just click into it within the EHR, and they weren't
See,
taking the time.
so I guess that's a different definition of integrated than I have, because to me integrated means that it's the data is combined and a normal part of the workflow that you have when you're doing whatever tasks. And it doesn't mean that there's some way you can get to it
Yeah, that
from within
likely
a
will.
system that you're already using.
Yeah, that
And that
likely
may be an interesting
is.
difference in definition.
That is a big difference in definition, and one that likely isn't going to happen anytime soon. And there's reasons for that. Obviously, um, data structures can be slightly different. Most EHR vendors do not want outside data being incorporated directly into the native source data that's being generated within the EHR just because of things like data integrity, assurance of data quality, all those sorts of things that are built into edits and other sorts of mechanisms within those workflows of creating those notes and creating those data elements. So I don't know that that's going to be happening anytime in the near future. I don't, it's
I mean,
hard to
because
say,
that's
but
certainly the point. I mean, to some extent, it has to happen for some of the. Certainly, it has to happen um, on the the payer side or even on the provider side to some extent, the provider access APIs will be not useful if that's not happening. But even on the, I mean, there are certainly on the payer side, and obviously that's outside of the EHR workflow and not pertinent to hospitals, there's an expectation that data once available, that any clinical data once available is available to all of those APIs that use clinical data, regardless of where it comes from and how it comes in, et cetera. So I don't know, I guess that's an interesting point. It never would have occurred to me that someone would consider the scenario that you're talking about integrated. To me, that was, because the data is not integrated.
I mean, if it was integrated the way you're describing, then how would they distinguish the 42% that isn't being used, right? It would have, if it was truly integrated the way you're describing, then it would automatically be used by those clinicians because they wouldn't know where the data came from. It would be just, a list of problems or medications or allergies or whatever it might be. So the fact that
I
it's
guess,
indicated here as a separate number tells me that they have to go, essentially retrieve
well,
that
I
outside
guess,
information.
it could be a filter of, I mean, I guess I was assuming that was happening via provenance. Um, and I guess in an ideal world, there might be a filter just to if data glut is an issue. But that's an interesting question. Um, I don't know, because one of the downsides of these data briefs is that they give really good data for what they give, but there isn't necessarily. I mean, it might be worth dropping an inquiry note to ONC about it, about asking about that. Um, but that's a good point as well. And this is why we argue about definitions in some of these rules, right? Because they matter. They make a big difference. All right, let's move on. So this is really an infographic, but it was promoted as a report. And really the key pieces in there are that the two pieces of information that I think are useful is that in Medicare Advantage programs have over 1 million denials a year, and OIG determined that 13% of them were for services that were found to be medically necessary. So that's a pretty high, quote unquote, bad denial rate. And it's not clear how many of them were appealed and overturned, etc. But that's kind of the other stuff that's on this is like they talked about activity that's happened around prior auth, and they mentioned the January 2024 rule, but they also mentioned a rule in April 2023. And I don't know, Dave, if you know what they're talking about. The main rule in April of 2023 was actually hospital price transparency. But the hospital price transparency rule did have other Medicare components to it, but there was nothing that was noticeably prior author we would have talked about more than the price transparency part of the rule. So
Yeah, I'd have to go back and look at the calendar and see what took place back in April.
yeah, I tried taking a quick look to see if I could, and that was the main rule was the hospital price transparency. And there were a couple, maybe there was some stuff shoved into one of the payment. I think there were some other like more routine, like this rule happens every year, didn't call out anything special. So maybe there was something in one of those. But in any case, it's kind of a spiffy little poster. I thought it was worth calling out those two data points, so I went ahead and included it. But I wouldn't really consider it a report, and it really those two data points are the only thing, the only main data that's there. So let's go ahead and move on. So CMS has also released a plan for health equity. And this is sort of, so CMS had put out their overall strategic plan a while ago. I want to say like towards the beginning of the year. And we had looked at it then, and it has sort of 6 pillars that they're focusing on, one of which is health equity in of its own. So what this does is it takes it looks specifically at health equity, and it looks at they put out these goals that are on this page, and then on the next page, we'll talk about it a little bit, but it basically puts specific actions under each of those 6 pillars that are in the main strategic plan around health equity. So it's about 12 or 13 pages long, and it's basically a series of paragraph long bullet points that sort of each highlight after these goals, which also are paragraph long in full. But this is sort of the part that they sort of have a title and then they keep going. They I'm not going to read all of them, so let's go ahead and go to the second sheet. So these are the 6 pillars, and they basically put, again, these like paragraph bullets of specific actions they're looking to take to improve health equity within each of these areas. So as you can see, one of them is just advancing health equity generally. So it's a little bit recursive. But so it's interesting. It's about, like I said, it's about 12 pages. It's actually pretty dense. There's a lot of, because they did these paragraph bullets, there's a lot of material in the report. And you can find it at that link. Any questions or thoughts or comments there? All right, let's keep going. So NIST has put out what they're calling the 2023 Cybersecurity and Privacy Report. It is actually primarily a list of sort of a toot our own horn report. It is primarily NIST activity. So it's useful if you want to look for, oh, did I miss a report on something that I care about that NIST has put out or something like that. Or if you just want to get a sense of where the industry is as a whole. But it's not, it's really not meant to be like actionable stuff. But it's still interesting if someone's interested in that area. It's worth taking a quick look at, and you can find it at the link there. Any questions there? All right, let's keep going. You'll pause there for 1 second. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. That email address is also on your screen.